Okay, hopefully you all are back from your video. Hopefully it was a good experience and you got to see a little bit of what DTs could potentially look like if they're not treated well. So when we're monitoring, and I'm going to go through this briefly because you're going to see a video on it in a bit that goes through it much more thoroughly, but the factors that we're monitoring on the CIWA include nausea, vomiting, tremors, anxiety, agitation, proximal sweats, orientation and clouding, tactile disturbance, auditory disturbance, visual disturbance, and headache. So those are, when you look at your scales, hopefully this is going to make sense because those are all of the things that you're assessing for each time you're performing a CIWA evaluation. So the nausea, vomiting is going to go 0 to 7. And one of the big critiques, and we can speak to this and maybe ask questions at the end, you'll notice not every number on the scale has a descriptor to it. So what makes something mild versus intermittent versus constant? How do I know if it's a 5 or a 6? We're going to talk about that a little bit more, but just know that that is one of the critiques of the tool, that there are some things that are not clearly outlined and does rely on your clinical judgment to it. But we're going to look at how much are they vomiting, and we say like food is medicine, right? So if they're not able to or not willing to try and eat, then nausea could be a component of that. So we really do encourage them to try and use their antiemetics if they need to, so that we can see how the body is responding to that food. So tremors, again, they'll speak to it as well, but if it's no, you won't be able to see or feel anything. The lower scales, again, it's not really going to be visible, but if you hold out and touch their fingers, you'll be able to sense it just a little bit. You can be doing multiple things at once. So if you're looking at, the sweats or proximal sweats, sometimes those are on the palms. So at the same time you might be checking for tremors, you might also be checking for sweat, or do you feel anything on the palms of their hands at the same time? Now we do have those people that like to go, oh yes, I'm withdrawing, look at my tremor. Maybe there's some medication seeking components of that. So if you're running into that, and I think the video speaks to it as well, extending the tongue is another great opportunity to see, because you'll see the same vacillations in tremor because it's a systemic tremor if it's actually visible, but the tongue's a whole lot harder to fake than the fingers. So sometimes that's a little trick to help out as well. Anxiety, again, this is their subjective experience of the anxiety, but also some of this can be seen in terms of how hypervigilant or how much attention they might be needing to pay attention. Agitation, again, this is more psychomotor agitation, not thinking of agitation as in mood agitation. So it's not, are they angry, upset? Because a lot of our folks are angry, upset for a variety of reasons. This is when they're talking agitation, psychomotor, like how much is their body moving? How much can they contain that energy or not? The proximal sweats, again, goes from 0 to 7. If it's a 7, they will be drenching through their clothing or their gown. If it's a 4, you'll see it on the face and in the peripheral. Orientation, and again, this is part of our daily assessments anyway. It can be handled sometimes just in conversation, but you can assess it formally as well. If you're waking him up in the middle of the night and asking him to count backwards from 100, they're probably not going to be very pleased with you in terms of your assessment of orientation. But the simple questions of making sure that they can speak to where are they, who are they, like, again, not everyone relies on memory for calendar these days. We all have apps and phones and things like that, but you do want to be assessing for increase in disorientation, because that can be, again, that second or third day, really important to catch on to if it's becoming apparent they're getting more disoriented. With tactile disturbances, again, this can go from anywhere from mild kind of itching, pins and needles, to full hallucinations. The more moderate ones could be intermittent, where it kind of comes and go. They still have those sensations, they're still responding to it, but it's not continual. By the time you get up to 6 or 7, these are going to be continual hallucinations. And this, similar for the tactile, the auditory hallucinations, again, it can go from just like a little bit like a did I hear something, like kind of they're not sure about it, at a more mild state, to a more the intermittent experience of hearing things, or that it's sort of at the beginnings, it's more like everything just seems really loud. It's not that they're hearing things that aren't there, but as you get into moderate to more severe, they are in fact having a full hallucination of something that's not there. And then as you get more 6 or 7, it's continual, like it doesn't stop for them. And the visual disturbances, again, at a mild basis, it would be more like the lights just seem really bright. So when we're going in, turning on the light, there's a reason that we're turning on the lights. Not only should they not be sitting there in the dark all day, but we're also checking for sensitivity as well. As it gets more into the moderate, it becomes not just that they're sensitive to light or that colors seem a little bit off. It becomes things start to change and they begin to see things that aren't there. As it gets full, more to the 6 or 7, again, severe and continual hallucinations. So what we would call corporal, where it's like it's something, actual thing that they're seeing. It could be, spiders, people, dogs, but it takes shape. It's not blurry. It's not just, I thought I saw something out of the corner of my eye. It's a fully developed hallucination at that point. For the headaches, I think we're pretty used to assessing for those, but it's not just pain. Again, it can be pressure. It could be like they describe it like a band around the head at a mild state, but as it gets more moderate to severe, somewhat we're relying on patient self-report of how disturbing or uncomfortable that is, but we don't want to miss the headache component of it as well. So with the benzodiazepines, again, this is our preferred sort of course of treatment in terms of medication. They have different half-lives. They have different ways that they're metabolized. So most of them being, metabolized hepatic metabolism and excretion in the renal. Are things like our Librium. It's more consistent in terms of the half-life. That's why if we know we have a really habituated drinker, that's kind of the preferred dose to have something scheduled, like a Librium scheduled, and then maybe using an Ativan or a Valium for breakthrough symptoms as needed. Because you'll notice from the Ativan, the half-life is all over the place, anywhere from 9 to 21 hours. So it's really more difficult to predict how much medication's in the patient's system, whereas things like Valium much longer. So we have 30 to 60 hours. So that's why we're moving away from using that as the scheduled medication. More if we need to schedule, we lean toward the Librium. There are some other medications that have been shown to be utilized for sort of treatment resistant. The phenobarb being one. We have a couple doctors that like to use that if somebody has had a lot of challenging detoxes before, they might do phenobarb ahead of time. But the first line of defense is still benzodiazepines with alcohol withdrawal. So we threw this in there just as a reminder, standard drink, like, what is it? Sometimes we've heard it's probably pre-existing COVID, but sometimes people say, oh yeah, I only have 1 drink a day. And we're like, is that because you put the straw in the whole bottle and drink it all? So what is a standard drink? Again, for beer, regular beer, not some of the specialty, more concentrated ones, it's about 12 ounces. Again, table wine, about 5 ounces. So if you see those glasses that a lot of restaurants have, and if you fill it all the way up to the top, that's probably about 2.5 drinks, not just 1. So you want to kind of be aware of what a standard drink is. Sometimes our patients like to describe it in terms of the type of bottle that they purchased as well. So for, a shot, it's about 1.5 ounces. That would be considered 1 drink. Some people say, oh, I drink a pint a day. When I started, I was like, I don't know what that means. Like, I think we drink a pint of beer. Like, what are you talking about? So if they're talking about the pint bottle of alcohol, that's about 10.5 shots. If they're drink a fifth, some people say, oh, I drink a fifth a day. Fifth is about 17 shots. A liter is about 22, and a handle is about 39 to 40 almost. So that's how it translates into what an actual shot looks like. For the cross tolerance, so if we think about if your maths are working, if your math works right. So for alcohol, if they have 4 units, so they have maybe 4 drinks a day, according to the reports, then the cross equivalent of that, cross tolerance, so about 25 milligrams of Librium is what we would expect would bind up about those same GABA receptors as 4 drinks a day. Be 10 milligrams of Valium, 1 milligram of Ativan. We don't see Cerex as much, but just as an FYI, that would be about 20 milligrams as well. So if you look back at, so if they're drinking like a fifth a day, 17 shots. So 4 times 4, 16. So I would expect probably around 100 of Librium would be required a day, something like that, math-ish wise. And again, it's not exact equivalence, but it helps us anticipate if we know a bit about that, like what might we be thinking that they might need. If we look at additional types of interventions, again, thiamine replacement, those B vitamins, it's along the lines of if we have any kind of Wernicke process going on, we don't want it to turn into coarse cough. We don't want them to have Swiss cheese for brain. So replacing those vitamins if we can, the folic acid, magnesium being another one. If they've associated smoking with it, doing any kind of, like, get them a patch, like, you know, because obviously they're not going to be going out for smoking here, but we have had instances where the agitation when they're going through the withdrawal for multiple things, from the nicotine, from the alcohol at the same time, just increases that agitation. So if we can do the replacement, we try to. Obviously the fluid. Other things that we think about, we do see beta blockers used to help manage hypertension that can spike in terms of withdrawal. But again, if we're just treating the hypertension and not treating the withdrawal, we don't have great outcomes. We need these things to kind of work together. So we do the clonidine, sometimes anti-seizure medications, particularly if they've had seizures before with withdrawal, we might do something just preventatively. And antipsychotics we talk about as well, but if they are getting into the hallucination stage, we may use antipsychotics interspliced with the benzodiazepines to both try and help with the symptom management, but also oftentimes that comes with agitation and impulsiveness as well. Other things that we want to also be thinking about with all of these withdrawals, this is not specific even to alcohol withdrawal, but hydration, nutrition. So think food is medicine. We got to try and get that system working again. If we can get them up and walking, again, that's across the board, helps with delirium prevention. If you know, they're super unsteady on the feet, we want to, you know, look at that in terms of safety, but we do want them up out of bed. Nobody's going to detox well all alone in a dark room for 3 days. So we need to get their circadian rhythms in line, think about sleep hygiene, visitations and stimulation. Again, you know, we have to look at not letting them just sort of sit quiet and do nothing with them. Seizure precautions, fall precautions, aspiration precautions, all of those are part of the withdrawal, because our goals are to reduce the symptom severity, prevent the manifestation of the more severe symptoms like seizures and DTs, and if possible, allow facilitation of a patient into a treatment program to support long-term alcohol abstinence if they're willing. So that's when we really want to get our social work case management, substance use disorder navigator, our SUDS person in to work with them to see if, you know, if we're going to go through all this efforts and try and get them detoxed, or even if they're here for something else and we're just managing their detox, you never know when that sort of drop in the bucket is when they're ready to get into treatment. So we want to always make that available to them to the best of our ability. So as we go through the presentation, your proctors are going to be showing you a little video. So I'll give a pause for them to do the video and demo.